Good morning, good afternoon, good evening, wherever you are. My name is George Kovac, and what at nowhere means is that I'm not on any form of active social media. If I've got something to say, I'll usually post it on Airway on our YouTube channel. So this is where I live in Halifax, Nova Scotia, and where I work at the Halifax Infirmary Emergency Department Trauma Center. And more importantly, this is where I hang out as often as I can. This is a place that I built about 40 years ago on a river, and it's a place of refuge for mind, body, and soul. And if you've seen this before, I apologize, but I'm going to keep on showing it. It's a play where it's a work in play. It's always work in progress, and plays changed over time with different tools. And I get to play with an expanded family. This is my crew, and together we're I guess 10 with 5 dogs and so a couple grandkids there. I do need to acknowledge my support that I received from Dalhousie University Department of Emergency Medicine. I need to pay tribute to those I've learned from in teaching and being involved with our Airway course for over 25 years, and also the relationship we've had with CAPE over this period of time. So the subject of this talk is high fidelity simulation for procedural skill learning and the problems with plastic. This is going to be, as it often is with me, lessons from life. There'll be lessons from imitating life, and then lessons from after life. Again, I always pay tribute to my greatest teachers, and they include the learners that I've been involved with along the way. But this is Rob Sandusky. Rob Sandusky is a close friend and was the program manager for our clinical cadaver program as part of the human body donation program. And those people who have donated their body as part of this for us to learn have collectively saved more lives than I ever will or we ever will in our lifetime. And I'm truly grateful for the honor of being able to work with these humans. I start off with a case, and we get sent a lot of vignettes from experiences that people have had after they've been involved with some educational events that we've offered over the years. And this is one from not too long ago. A 31-year-old healthy mother of 4 entered emergency department, community department, with normal vital signs and a sore throat at 5 a.m. By 6 a.m., she was imminently obstructing her airway with invasive group A strep epiglottitis and a concomitant infection of the deep space of her neck, of this patient's neck. And for context, this is a general practitioner with extra training. There were 2 nurses. There was no backup, and it was a long transport time. Again, I will apologize, but then take away that apologize. My apologizing for this, because you've probably heard it before, I go back to when I finished my internship on a Wednesday, and that following Monday I was working in a small community hospital in Cape Breton. And it was a crazy scenario. I thought I knew everything. I, taken ATLS and ACLS, and then some badness happened. It was myself and 2 nurses, and that badness involved a car versus train. And I'm not going to go back into the details, but ultimately it was motivation for me to go back and seek further training. And that training was not only in emergency medicine, but also I did a master's in health professions education at the University of Illinois. The retired red sneakers are a story for another time. And ultimately, this was motivation to come back and deal with what was scaring me, which was airway management. And this is the equipment of AIM on the road, which I said has been going on for over 25 years. As I have done in the past, and what's going to happen here, I'm going to frame the remainder of this talk on simulation and the problems with plastic around the 4 C's. And the 4 C's are based on conversations that I've had with my kids as they were growing up, and the C's of success, and they've grown from 4 to 5 CCs, and ultimately it might even be 10, but I'm going to talk about 4. That's competence, context, confidence, and conscientiousness. And I can talk about this in reference to being a parent of 4 adult kids and also being now a grandparent. Simulation in its most basic form is about trying to make it real. What are we trying to simulate? We're trying to simulate real world experiences. In order for us to get patient, learner, and provider, ensure patient, learner, and provider safety, simulation is about, in part, is owning that room, being able to whether that room involves you and another colleague, or whether it's a full gaggle of people that might be in our resuscitation room. But in order to own the room, you need to own the tasks. In order to own the outcomes, that's what's required to ensure that you have good patient, learner, and provider outcomes. Simulation's been around for a long time, and we refer to our aviation colleagues as being leaders. And this is a very first generation simulator, and there are all kinds of medical simulators that have been out there for quite some time. And probably the modern day one that we've all referred to is Annie for CPR training. And procedural education, procedural training, many people still quote what Halstead stated back in 1989, the term see one, do one, teach one. Many of us are, in retrospect, critical of this statement about the number of one, but the principles still apply. It's about seeing this, understanding what the procedure is, doing the procedure in the context of a learning venue, and really what teaching it represents is that you've reached this level of competence that you are able to teach it. And we have to build on that, and I'll give some examples of that in a couple minutes. 135 years later, we've got competency by design. And in principle, it completely makes sense, is that we need to move away from time and numbers to assessing that our learners are competent before they go out into the real world. And from simulation, I'm going to refer to this excellent graphic by Petro and Hicks from Toronto about the zone of simulation. And we can use simulation for all kinds of things. Where it applies, certainly in critically ill patients, is high acuity, low opportunity scenarios. And if you think about it very basically, which I'm going to do, is you break it up into team and individual. And team really is about making good decisions. Now, procedure is only good as a decision that's there to support that procedure, and it's about having a shared mental model so that you can all execute that clinical care at the bedside and those procedures in a way that benefits your patient. When we think about task execution, though, as much as it's a team behavior, the individual holding the knife or holding the laryngoscope or whatever it is needs to be skilled in doing that. And if you go back in time in emergency medicine, this is a paper that goes back a while. Originally, the list of procedures for emergency medicine for us to be competent and the frequency survey associated was 127. This was not so long ago a survey of program directors listing 32 essential procedures, but in the procedures where it was not deemed important by a majority of program directors, it was really based on the lack of practice opportunities. So things like emergency department thoracotomy, extensor tendon repairs, thoracentesis, vaginal delivery, lateral canthotomy were not deemed to be important. And again, the basis for this was that there weren't necessarily adequate simulators for this, and we couldn't guarantee the experience of our learners. Now, the public would expect that if somebody comes in with a life-threatening injury in the appropriate context, that we are able to perform these procedures. So procedural skill, outcomes, again, competence, context, confidence, and conscientiousness. And when we talk about airway success, which will be the focus in which I'll frame the procedures around, we have to optimize the conditions of the patient. We have to optimize the conditions of the environment, things we have access to, and supporting that patient care. So let's begin with competence. There's a very famous paper by George Miller, published in Academic Medicine back in 1990, and this hierarchy of competence of those who know how, show how, and ultimately do. And when you think of it, competence is really an educational outcome. It's something that we are measuring. And historically, the way we've measured this is how many and how long. So how many of the procedure that you've done, or how long has your rotation been in anesthesia or critical care or whatever it is. And it's about showing how. You have to demonstrate that competence. And there's numbers needed to competence for various procedures, whether it's 10, 50, 100, or whether it's 6 months, 12 months, or 5 years. The answer here is that there is no answer for all the individual procedures, and they have to be customized to the individual and the context. Now, Malcolm Gladwell, and he's making a bit of a comeback with a recent book that he's reflected on how he might have been wrong in some previous things that he's written, but he hasn't addressed this one so far, and I refer to it, so that's good. It's the book Outliers, and in the book Outliers is a chapter called 10,000 Hours. What 10,000 hours roughly corresponds to is about 10 years. And that's meant to sort of describe what it takes to ultimately be an expert. And that the people that are experts and are at the top of their game spend a lot of time practicing whatever it is that they do. My kids subsequently remind me that the artist Macklemore, who I very much enjoy, said in one of his songs called 10,000 Hours, the greats weren't great because at birth they could paint. The greats were great because they painted a lot. Now, Anders Ericsson, I think is a hero to many of us, and the buzzword has become deliberate practice. So what does that mean? In its most simplistic way, deliberate practice is about practicing the procedure, but not independently with just a trial and error scenario. It's having timely feedback by somebody who's experienced, who's able to modify what you do so that ultimately you have a successful outcome. This was 1996. I wrote this paper called Procedural Skills in Medicine, linking theory to practice. And in the awesome graphics that we had back then, this was referring to Adams' closed loop theory. A psychologist who wrote this in the 1970s about how we learn procedures. And to me, this is what I refer to as a deliberate practice event. Now, this has evolved, and other people have quoted this paper, and to me have expanded on it in a very worthy way. Sawyer, in particular, learn, see, practice, prove, do, and maintain. Still talking about these deliberate practice events, but that we have to expand it beyond what the original dogma was. So I'm going to take you through what a deliberate practice event would be, at least my interpretation of it. It is using Adams' closed loop theory in the 70s. So let's say you go in with a laryngoscope, and regardless of type, you go in and you can't see diddly, or you just see the epiglottis. And what's happening is there's sensory feedback that's happening in the room. It's got to do with the force that you're applying, that sensation. There's also that auditory sound of perhaps a tachycardic patient or saturations that are falling in. All that sensory input needs to be perceived. And without having somebody that's there to give you feedback, then really it is trial and error. And ultimately, you'll play and you might be successful and get the right result. But that's not what should happen. This is when you have to have somebody that's able to give you that feedback. This is the beauty of video laryngoscopy, and it becomes a team sport, is you can get that direct experience from somebody else in the room. And then you have what's called knowledge of results. In other words, that you are in too far, lifting too hard, or lifting too proximal, and then you can alter it and make adjustments that you need to do so that you can place the tracheal tube in the right place. So competence is what we've referred to, and historically it's been how many and how long, but I don't really care about competence to a certain degree. What we really care about is what happens in the real world, performance. What are the outcomes? What's the morbidity and mortality associated with these procedures, with whatever we've done? And for airway management, it's been historically first pass success, which I really don't care about. What I care about is first pass success without adverse events. And these are examples of performance markers that we need to mark to know whether we're going to have reasonable outcomes. So somebody might say, well, you only do X number of intubations, or that you've only spent X number of months in your rotation in anesthesiology. Well, I don't care. If you're getting results as they do in Minneapolis in an ED, where they have 98% first pass success when they routinely use the bougie with objective observation. So, how real, and I think when we talk about how real in terms of context, so we talked about competence. In context, we need to break it down in terms of the simulation and the simulator. So this is something that you might have seen before.
Stan. State-of-the-art computerized patient simulator. Stan can educate you in airway management, trauma assessment, and care. He breathes, he pulsates, he seizes, he hemorrhages, he secretes, and he speaks. Hello, Stan.
Hello, doctor. I'm not feeling well.
Stan will tell you what he needs, and he's more forgiving than most patients. If you kill him, he'll keep coming back for more. So make good use of him, people.
What's the matter? Scared of a little education?
You are so awesome. You are so awesome. No, stay. Come on.
I cannot help it. I'm dying.
I'm applying
There
pressure.
must be something you're forgetting.
Oh, for crying out loud!
I'm surprised you even passed your intern exam.
Oh my God. Clear. Yes. You don't get to die.
Nice job.
Oh, hi. Thanks. He's just a robot. want to take back what I said before about leaving. I was overreacting. It was personal, and I wondered if you could just forget about it.
Get some sleep, Dr. Hunt. See you tomorrow.
All right, so simulation and the simulator. I talked about this briefly, but I think from a broad perspective, simulation is about team dynamics, about sharing a mental model so you can work together. You know when a procedure is indicated, and you know how to assign and perform the individual tasks. And again, the outcome of that patient's not going to be just about decisions. The person holding the knife, holding the laryngoscope, holding whatever it is needs to be good and more than good at that procedure. And it is this zone of simulation where we can amp things up and at least create that socio-environmental stress that is meant to mimic the real stress of a clinical of a patient. And I refer to this as your psychological shock index. When your psychological shock index is when your heart rate is greater than your patient's heart rate, sometimes that can have a negative effect. So simulator, it does matter in terms of task execution. We talk about validity, simulator validity, and there's face validity, and we've made a lot of progress on that, and that's how the simulator looks. Construct validity is whether it's be able to differentiate from a junior learner to a senior learner, and ultimately really what we care about is predictive validity. Does it predict how people perform when they're out in the real world? So validity is really about well-founded and how well-founded and likely it corresponds accurately to that real world. When we think about simulator fidelity, unfortunately we've been too simplistic and we think about low fidelity and high fidelity. And I want to break this up into technologic, physiologic, functional, and ultimately ontologic fidelity. So low fidelity usually refers to no bells and whistles. It will give you some anatomy basics, and high fidelity from that video that you just saw previously, and that's based on technology, and that technology is closely associated with cost. And if you want to get a SimMan or various other things, we all are very much aware of the expense of these particular procedures. And yes, they can do some impressive things. And the cost for basic components of this can be upwards of $50,000. And then when you get the add-ons, close to $100,000. And then the replaceable items can be extremely expensive over time. And that's been the simplistic way that we view low fidelity versus high fidelity. And we make this impaired assumption that high fidelity is better. So team decision making from a fidelity point of view, there's some literature actually that came from our institution here in Halifax, looking at fidelity of simulators. And again, low physical fidelity simulators, at least in this study, were not inferior to high fidelity simulators for teaching non-technical skills in terms of decision making. So let's look at physical, and this is about appearance, anatomy, and feel. And there's no question there's been huge changes with this. I mean, you walk up to these, they've got 6 o'clock gross. You feel like you really do have to walk up and say, hello, how are you doing? Because of how real that they look, and how that we've moved away from plastic to silicone and other things that make them feel less or more realistic, let's say. And when you look at, let's say, from an Airway data, and you look at various simulators, and this is an example of looking at various simulators that are out there, and you compare them to CTs, as an example here is the anatomy of 4 of the most common high-fidelity patient simulators and 2 Airway trainers do not reflect the upper airway anatomy of actual patients. And this is where it really gets important, because this is where I think we're doing an extreme disservice to our patients, and in fact it actually promotes bad behavior and bad outcomes is functional fidelity. And this is how they respond, and that it promotes good technique, and that you get an action reward. If you do what you're supposed to do in a real human, that you're going to be rewarded with a better view or whatever it is, as opposed to a scenario, if you don't perform it well, then you're not rewarded with it. I'm going to break this down into the airway skills that I'm interested in, begin with laryngoscopy. It begins with positioning. Sniff. What are the key criteria that a simulator from a functional fidelity should have? Positioning. You should be able to position them, and with that positioning, that you get an improved view. Whether you sniff upright, or whether it allows them to do face-to-face procedures, whether you're doing flexible endoscopy, etc. None of the cadavers, none of the mannequins that are around are able to do this in a high functional fidelity manner. It's from an epiglottoscopy that if you do this properly, you can do this with 2 fingers, just gradually moving things down, engaging that median glossoepiglottic fold, and then displacing that. Volleculoscopy. This is the median glossoepiglottic fold. This is where your blade should be. And if you looked originally, it was shaking and it wasn't moving. Whereas in this second video on that same cadaver, this is just 3 millimeter difference in terms of positioning. Then you're rewarded with a good view. And that's the difference between somebody experienced and somebody not experienced, somebody having a terrible view and somebody having a good view. And the beauty of being able to share this with video laryngoscopy and feeding back, saying, listen, you're not down too far enough with your blade tip. And then ultimately with laryngoscopy, that you're able to manipulate position and be rewarded with a view. And with intubation, and that you have a realistic response to various maneuvers when placing a bougie in the right place and trying to keep things off structures. And that when you're in the wrong place, which is not an uncommon scenario, because what happens when you're adrenalinized and you have a big blade is that you seek it deep, and you pray that you're in the right place, and you use all kinds of lift, right? And you'll use that lift and you say, geez, there it is, and you place that tube recognizing that you're in the wrong place. So there are no simulators out there that have this physical fidelity. From a face mask ventilation perspective, the ability to face mask ventilate somebody easily with somebody with teeth versus somebody who's edentulous, that you have a gravity-based functional obstruction, that your mannequin is supine, that things fall posterior, that in order to get effective movement from a ventilation point of view, that you have to do an appropriate jaw thrust. That you're able to relieve that functional obstruction, and you get that jaw thrust reward. From a face mask ventilation, here is seal management. And I'm going to give an example. This is, again, a cadaver with an open lung window, and you were unable to ventilate this edentulous cadaver, clinical cadaver, until you make some movements and make some adjustments, and then you're able to get that response by looking at the lung window. Now, I'm not going to suggest that our mannequins have lung windows, but there's very easy ways to do that, so you are rewarded to actually see ventilation. And this is a maneuver that we're about to publish, and something we've just learned over time with simulators is that it's all about lifting in the right place and then using spare fingers to deal with that seal and seal management. And I'm going to spend a couple minutes here, because there's situations where you will have somebody that's not saturating well, and you think that you're bagging the patient. I just got abandoned it and going with the laryngoscope, where if you were to apply use a waveform capnography, you'd see that you have a poor seal. Waveform capnography is the equivalent of having an open lung window where you get breath-to-breath feedback. You'd have a poor tracing, and with that poor tracing, you make the adjustments, and then those saturations would rebound from wherever they are at 80-something to something that's well in the 90s, and it would be safe to proceed. There are ways to do this with our mannequins. And again, this is an example of the powerful PEEP here, is just putting a PEEP valve on and seeing that within 3 or 4 breaths that you would be able to see with your waveform is that you have recruited alveoli, and any more aggressive ventilation that happens to that is lowering their CO2, causing vasoconstriction in their head and causing badness. And so there are ways that we can do that, and currently none of our simulators have that functional fidelity to reassure that. From a supraglottic airway, we just place a supraglottic airway, squeeze the bag, and we hope that we're in. Again, some mannequins might reward that, but the most common scenario that happens is that the epiglottis ends up in the bowl, and you need to understand the anatomy, how to relieve that, which is pulling back your eye gel, doing an aggressive jaw thrust either manually or with a blade, and then the epiglottis will leave. So this is me going down with a scope in a clinical cadaver through an eye gel, and this is the median glossoepiglottic fold, and epiglottis is folded back. Obviously you wouldn't have good waveform, but I pull this back, right, do an aggressive jaw thrust, and then reseat this, right, and lo and behold, you're able to now ventilate that patient. So understanding that maneuver and being rewarded with benefit. And from a front of neck airway or cricothyrotomy, another big pet peeve about this is that all of the simulators for performing cricothyrotomy really reinforce bad behavior. There's incredible mobility of that larynx in somebody that's about to die. And the biggest error is not stabilizing that larynx and you going paralaryngeal with your blade and ultimately with a bougie, and you're not being in the right place. That they are ultrasound capable, that they have some tissue separation, and that they have an ability to bleed. Now, up in the top left here, that was the first simulator that I built from a Canadian Tire and Home Hardware. I'm not sure if Home Hardware is actually a piece of maple, and some plumbing hardware. The red is meant to be inferior, right towards the feet, and the black superior, and allows you to sort of put a skin over that and palpate it and do it. And this is what we used in AIM for some time, and then there's various versions that have come out. And this is the most recent one that we use, and I think it's the highest fidelity and simplest and least costly of it all, and involves a 3D printed larynx, so an extended larynx that is flat in the back, that requires you to stabilize it when you put it on the desktop, and then you have your required equipment, and then we have a menu of how to make these reinforced skins thanks to our simulation program, and you make them at various thickness, and creating one baking tray of this will give you about 50 to 60 cricothyrotomies in a single go. So this combined equipment costs about $75, and most realistic. This is an example. You just take some paper tape, you put it on, there's your cricothyroid membrane. You can do that as many times as you like. Right, you've got your 10 blade, you've got your number 6 tube, and I've got this reinforced skin, right, that won't just tear as you put it in. You have to stabilize it here with your thumb and your index finger to see that mobility. You palpate up from the sternal notch, make a vertical landmark incision, separating tissue. Now your finger goes through and you feel where you need to go. You incise, you extend in both directions. You stick your finger in. You will never forget that feeling of having cartilage surrounding. And then you place the bougie behind your retracted index finger so you can feel it, and follow with your number 6 endotracheal tube that you tent the skin to place, and you've placed it there. And that is as realistic as you're going to get. And the number of emails that I've received over time of people learning it with this stuff that they have, and then doing it in real patient is pretty significant. So high acuity, low opportunity challenges. The irony is where the literature goes back, and this is what my thesis or my project was on, is how we do this. It's about what you're supposed to do. Ironically, you're supposed to overlearn and then do what I refer to as system 1 education. So overlearning means just doing it over and over until you're not just competent, but it becomes second nature. And then what happens is, over time, when you lose that skill, then the next time that you learn it, it's an easier learning curve, and you more quickly achieve it. And then the time that you lose that skill over time, it happens over a longer period of time. System 1 training is these are the 11 steps required to perform an emergency cricothyrotomy using a bougie finger approach. Or a finger bougie's approach using a scalpel. Those are the 11 steps. That's a practice opportunity. I've got the psychomotor skills to do that. And then again, you've just sort of seen this being done. I'm not going to go into a bit more detail. You keep applying the tape, you move the skin over, and you do it over and over again. If you have the opportunity to do it with clinical cadavers, and you can actually feel the space, and you get to feel what it's like to have cartilage in, and then ultimately place it, and then we can look at the lung window or go down with a scope and see that you're there. This is an ultimate practice opportunity. And then we can create more scenarios where it's actually a bleeding airway. And then there's the additional things that we can increase heart rate, which is somewhat of a marker of causing some increased stress in performing that procedure, so that that is an escalated level of simulation. So functional is where we're really missing the boat. But the one I will finish with, this one, is Ontologic. And this is really a tribute to an incredible research and human being by the name of Anna McLeod and her team that I've had the gift of working with. And those of you who know Anna as an educator, she does amazing work. And she has spent a lot of time looking at how we learn with various resources around us. And ontologic fidelity relates to how we interact and behave in that simulation setting. And she and we've been involved in some publications that I'm very proud of. And every year at the internment service, I read from a section from this paper, of another paper that she'd written. But ontologic fidelity refers to the degree at which a simulator matches what a real patient is, a real human person. Ontologic fidelity of cadavers was their greatest strength and inspired a very different type of practice. You'll see people that are interacting with clinical cadavers, and there's this sense of respect that's there. And it's not that we just tell people that you have to, respect the context and the gift that we have. It comes naturally. You'll see people that are sort of holding the shoulder or ensuring that eyes are covered and things are covered up during the procedures. That doesn't happen in other settings, and the sense of focus is very, very different. So simulation and fidelity, it does matter. We have to recognize that there are probably 5-6 simulators that are used for airway management. We have 8 billion people in the world, and every time we have the gift of a clinical experience with a clinical cadaver, we realize that diversity that's out there. So I finish up with two things: confidence and conscientiousness. But confidence, this is Mike Tyson. Mike Tyson famously said, "We all got plans till you get punched in the mouth." And if you're in this business, you will get punched in the mouth. And confidence and competence are closely related. This is a play on Dunning and Kruger, and whether you believe in the original 4 studies done by these psychologists or not, I think the principle applies is that when we tend to have the most confidence is soon after we've learned everything. And that was me when I finished my internship on a Wednesday. I just finished taking ACLS, and then literally as I said, a car was hit by a train and 2 patients came in. This was my sort of peak amount stupid, and it was humbling. And you might have that immediately after, as I did, or have it at some point. And then there is this, as we all are human, is that we have this valley of despair when something bad happens, and we reflect. And some people actually leave their chosen specialty or what they do as a result of this. And then this graphic is incorrect because it shows this slope of enlightenment and plateau stability, which is a bunch of bullshit. And really life is about ups and downs. And ultimately we hope we get a little bit better each time. And each time into my 60s, I hope I'm getting a little bit better. Confidence, this was a study that was not published, but it's interesting. If you look at airway management, you say, who feels most confident? People who have done 5, 10, or say 20 intubations. Who feels the most confident? It's the people that have done 5. And that's no surprise, because at 5, they haven't had the opportunity to experience badness and be humbled. So experience is needed to be confident. It just doesn't necessarily happen that often. Conscientiousness, this is, I'm going to say, the most important thing. It's about work ethic and working ethically. Work ethic means don't be upset by the results you didn't get with the work that you didn't do. If you don't spend the time putting in the work to be good at these procedures, then how can you expect to have good outcomes? It's incredibly unrealistic, and we can never let experience be our only way to competence and ultimately performance at the patient's bedside. Since passing the quiz or finishing your exam, how many people actually go and practice various procedures? We don't do it very often. Our colleagues, and whether they're athletes or fighter pilots or concert violinists, spend a majority of their time practicing and very little time performing, where we in medicine spend the vast majority of our time performing and very little time practicing. We need to deliberately address the things that we don't necessarily get experience. We need to deliberately address the things in context that we'll be able to have that clinical experience and good patient outcomes. Working ethically it's not about you. It's not owning the airway. It's about the patient. And I'll finish this. I gave a 4Cs talk in Atlanta a number of years ago, and this older physician that came up and said, George, you really forgot about this one, and this is a key one is compassion. And we spend there's rigorous data showing that healthcare providers spend more time looking into the computer screens and looking at patients' eyes. How many times do you walk down the hallway or walk through a zone and you'll have 5 people sort of sitting next to each other and they're engaged on their phone? And I'm not saying that this is not necessary, but I think it is a gap. And to me, the resurrection of compassion is really linked to your health and your ability to see through the eyes of others. And that's what my job is, to see through the eyes of the others, whether they be my patients or my colleagues that I work with. I'm going to go back to this case of this patient. that presented at the beginning, the 31-year-old who was obstructing with an upper airway, which is in a setting with really no support. And this was what the email went on. Said, by God's grace and training, I did an awake intubation using the glide scope. We transferred out to ICU and left that blessed 602 for the entire stay, as they felt the trach was too risky with the massive neck swelling. Would also love you to share this, Kate, with your airway community, as it reinforces why we do what we do, and why what you do. Prepare, practice over and over again in case a young mom of 4 kids obstructs her airway due to epiglottis in a hospital that has no OR, no anesthesia, no ENT, and no RT. Can you imagine? Thanks very much. The story about the red sneakers is, I guess, almost 30 years ago. I used to wear Converse when they cost $15. I used to wear white Converse, and they were white. And they got messy working in a merge, and some friends went down to Boston as a joke and brought me back red sneakers. And so up until a few years ago, where my feet can't tolerate these sneakers, I wore red sneakers, and they're all retired in my office. Thanks for doing what you do. Have a good day.